Hello, my name is Srinath Adusumalli, and I'm an assistant professor of clinical medicine here at Penn Medicine and the Hospital of the University of Pennsylvania. I'm also the assistant program director of the Cardiovascular Disease Fellowship Program, and I'd like to welcome you to another installment of the CVI Heartbites series. Today, we'll be talking about the role of echo and point-of-care ultrasound in the COVID-19 era. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbites segment focuses again on cardiovascular disease in the age of COVID-19 and the role of echo and point-of-care ultrasound. Please note, this presentation was recorded on April 29th, 2020, and the information presented here was up to date as of that time. At the end of my presentation, you will see additional resources and have the opportunity to contact me with any questions that you might have. I have no disclosures relevant to this presentation. Today, over the next 15 minutes, I'm hoping you, as the learner, will, at the end of the activity, be able to describe how COVID-19 has transformed the echocardiography laboratory, to be able to implement collaborative point-of-care ultrasound protocols adapted for the era of COVID-19, and to be able to discuss implications of COVID-19 on the future of the echocardiography laboratory, as well as echocardiography practice. As we all know from our work on the front lines, as well as from prior installments of the CVI Heartbites series, cardiovascular disease requiring echocardiographic imaging is associated with COVID-19, with the manifestations ranging from acute myocarditis all the way to the pulmonary embolism associated with hypercoagulable state in the setting of COVID-19. Echocardiographers and sonographers are at a high risk of acquiring the disease while performing echocardiographic studies due to the nature of how closely tied the performing provider of those studies is to the patient. Workflows and study utilization patterns need to be adapted to protect patients and providers while providing requisite information to deliver critical patient care. There's a great position statement put out by the American Society of Echocardiography, published in the Journal of the American College of Cardiology earlier this month, that is worth reading on this topic, which will be referenced throughout the presentation. It lays out several adaptations of the echo lab to the COVID-19 pandemic, starting out with what many of our organizations have already done, which involves deferring and rescheduling echocardiographic exams and particularly identifying deferring all elective exams, and then identifying and performing only urgent and emergent exams. And this is really based around the utilization of appropriate use criteria, and layering that on an assessment of a patient's COVID-19 status, whether one is COVID-19 negative, on one or how many tests they've had, whether someone is a person under investigation or suspected of having COVID-19, or whether they are confirmed of having COVID-19, influences the decision to defer or reschedule an exam. Additionally, labs need to be able to provide, and institutions, for appropriate levels of self-protection and personal protective equipment, particularly in the setting of transesophageal echocardiograms, which are even higher risk than transthoracic studies. And these should be deferred whenever possible and performed only in suspected and confirmed cases, only with airborne PPE precautions, and I should say in suspected confirmed cases of COVID-19. Additionally, and this is where the role of point-of-care ultrasound, or POCUS, comes in, there's an imperative to preserve PPE from institutional and national perspectives. And in this setting, point-of-care ultrasound can be critical in triaging which patients need to go on to further echocardiographic imaging. Additionally, again, non-urgent or emergent exams should be deferred if not completely necessary. Exams, when performed, should be limited and problem-focused examinations. And this can be guided by prior studies, including other imaging, as well as point-of-care ultrasound findings. The reading room itself, and we've done this at Penn Medicine, needs to be transformed using methods to reduce transmission. including putting into place methods for remotely generating reports, remotely viewing echocardiogram images, and accessing reporting systems, as well as to perform echo consultation. And this will discourage congregating in the echo lab reading room. And this consultation could be performed via the multitude of video conferencing systems that we are all using for telehealth and telemedicine practice these days. If presence is needed in a physical reading room, there should be physical frequent disinfection of surfaces that are present within that reading room. And finally, personnel who are at particularly at high risk due to these characteristics or otherwise should be identified and appropriately reassigned. All of this has really led to the birth of a collaborative point-of-care ultrasound environment. And this is born out of the need to limit the risk of patient and provider exposure to COVID-19, of limited availability of personal protective equipment, barriers to bringing large ultrasound machines into patients' rooms, and even more importantly, out of patients' rooms and decontaminating those machines. And then the need to empower frontline providers who are by the patient's bedsides to conduct examinations that are needed to safely advance care. And these efforts, and this is potentially one of the silver linings of the COVID-19 pandemic, have been a great example of collaboration across health systems from fields ranging from cardiology, emergency medicine, critical care, internal medicine, vascular surgery, and others. And this is one of the aspects of the COVID-19 pandemic and one of the care innovations that hopefully will live on well beyond COVID-19 pandemic period. So jumping now to point-of-care ultrasound and the approach to point-of-care ultrasound in the setting of COVID-19, the American Society of Echocardiography again did a nice job in another position statement focused on this topic, also released this month, in laying out the approach to POCUS in the setting of COVID-19. And it's really centered around first identifying a patient who has potential cardiopulmonary disease that requires an evaluation based on initial history, physical exam, laboratory data. And this point-of-care ultrasound exam can be performed and either be deemed sufficient to exclude or define any cardiopulmonary abnormality, in which case a more complete exam could be deferred, or it could be deemed that the POCUS exam is insufficient and echo is indicated. In this case, the POCUS exam can still be quite useful in focusing and guiding the performance of a more complete transthoracic echocardiogram. And this is a suggested protocol, and we'll go more in detail to this in a couple of slides as to how POCUS can be performed, starting with a peristernal long axis view, short axis, apical view, IVC, and I would add to this the internal jugular vein as well. And also to include lung exam in point-of-care ultrasound, which typically as cardiologists we may do, looking at normal findings such as A lines, as well as B lines, looking for pleural effusions, as well as lung consolidations. And I'll show you examples of those in a bit. This is the ASC COVID-19 POCUS protocol, which I think is particularly useful. And this is table 1 from the paper I referenced earlier. And it effectively involves first imaging the heart and looking for structures that may have particular relevance to disease associations in COVID-19. So for example, looking at the left ventricle for size, global and regional function, particularly keeping in mind manifestations of myocarditis, ACS, cardiomyopathy, and shock. Looking at the right ventricle for size and function, and if spectral Doppler capabilities are available, looking at TR for PASP, again with attention to PE and cardiomyopathy. Pericardium, looking for effusion and evidence of cardiac tamponade. The valves, looking for gross regurgitation or stenosis, particularly because pre-existing cardiovascular disease may modify how patients with COVID-19 are managed. Then, as I mentioned before, including the lung point-of-care ultrasound exam is important as well, whether it's for B lines that indicate the presence of edema or pneumonia, subpleural consolidation, thickened pleura, lobar consolidation with air bronchograms, or even effusions. And this can be done through an 8 or 12-point exam. And finally, the vascular exam is important too, from either assessing the JVP or subcostal IVC, looking for fluid status in the setting of heart failure or hypovolemia. And finally, the leg veins, using 2-point compression and assessing for deep vein thrombosis, particularly in the setting of the hypercoagulable state where finding is associated with COVID-19. Of course, safety first, and appropriate infection control practices must be implemented. And this is table 2 from that same paper. And although some of these practices may vary from institution to institution, it is worth reviewing and making sure all of these steps are implemented within the process of performing point-of-care ultrasound in the era of COVID-19. So I wanted to talk a little bit about how we've implemented these practices here at Penn Medicine. So first is we have begun a process, we and other organizations, of point-of-care ultrasound teleguidance in the spirit of the telemedicine and telehealth visits we all are doing. And this really is a great example of a collaborative effort in which remote echocardiographers and sonographers who might be either physically based in the echo lab, remote from the bedside, or even out of the hospital, can help providers perform echocardiographic studies at the point of care, as well as interpret or overread those studies. And this is an example of a platform that can be used to do this. That's a third-party point-of-care ultrasound platform that involves reviewing and looking and manipulating images remotely, as well as helping to guide through a smartphone camera the provider at the bedside perform an appropriate echocardiographic exam. And you can see here that there's even an ability in this particular system to show one using augmented reality how to move, tilt, or rotate a probe. You can also remotely adjust probe settings through this to be able to optimize echocardiographic images. And you can see here the picture of the consulting echocardiographer or sonographer is displayed here. This similar concept can also be done through existing technologies like EICU cameras that might be present in a variety of critical care settings where images and the performance of an exam can be guided remotely, as well as through iPads that might be deployed using traditional video conferencing software. This is an example of our point-of-care ultrasound protocol that incorporates these technologies and includes provisions to both overread an exam that has been performed, as well as guide a frontline provider who may need to be upskilled in performing point-of-care ultrasound, and then having those studies overread. If those studies are insufficient, they can then guide the performance of a formal transthoracic echocardiogram, if needed, to answer a particular question. What have we found with these protocols? So this is an example here from a point-of-care ultrasound study where we diagnosed clinical and echocardiographic tamponade. We've also been able to diagnose new cardiomyopathies, new regional wall motion abnormalities, pulmonary embolism, cardiac tamponade, as I mentioned, as well as deep vein thrombosis, all through the use of collaborative POCUS protocols. Additionally, we ourselves as cardiologists have been learning and breaking down traditional boundaries in terms of learning new modalities like lung point-of-care ultrasound. Here illustrated by these arrows, by A lines that are noted which are normal findings during the course of lung point-of-care ultrasound, as well as B lines, which again can indicate the presence of edema or pneumonia on point-of-care lung ultrasound. And we as cardiologists are now learning to recognize these as important manifestations that can help in the management of patients with COVID-19. In addition, it's important not to forget about documentation and image archival, which I think are just as critical in this era, because serial exams may be performed, point-of-care ultrasound exams, in comparison across the hospitalization, as well as across other hospitalizations is critical. And this is important for education, particularly in the setting of where we're upskilling individuals and trying to teach individuals how to perform point-of-care ultrasound, important for quality control and research purposes. All images should flow to clinical PACS or image archives to be able to be reviewed later for all of these purposes. And documentation should be structured and visible to all in the electronic health record to ensure that information obtained from point-of-care ultrasound is not lost. So I wanted to take 1 minute to think about what we can take forward from the COVID-19 pandemic period, what will persist from this period in the world of the echo lab as well as point-of-care ultrasound as we enter the resurgence from COVID-19. So I think that the collaborative workflows that we've developed during the pandemic will become the foundation for novel relationships, and this is enabled both through departmental, divisional, organizational relationships we've developed, as well as through cloud computing environments that enable the sharing of images and documentation in ways that weren't possible before. Handheld medical devices will become integral parts of the physical exam. This is an example of a digital black bag we've created here at Penn Medicine that includes a digital stethoscope and point-of-care ultrasound probe, as well as phones and AirPods. in order to facilitate this process. And finally, point-of-care ultrasound studies will become intertwined with other types of studies that are performed and interpreted in the echo lab, to the point that we discussed earlier, where point-of-care ultrasound studies could be used to guide and focus the performance of more complete formal echocardiograms. So I wanted to end with a set of acknowledgements that illustrate the fact that we're all in this COVID-19 pandemic together. And I think the point-of-care ultrasound world is a tremendous illustration of this fact, because the effort is very collaborative. You can see across our critical care colleagues, of course, our echo lab, the emergency department, vascular surgery, and many others have all contributed across multiple disciplines and roles in order to implement point-of-care ultrasound workflows that both keep our patients and providers safe while ensuring high-quality clinical care is delivered. So here are several additional resources on the role of echo and point-of-care ultrasound in the COVID-19 era. If you have any questions for me, please email CVI's Executive Director, Mark Hardnett, at this email address here, and those questions will be sent to me, and I will be happy to answer them. Feel free to share this link with anyone who might be interested in this information, and please let us know if there are other topics of interest to you. Thank you for watching the CVI Heartbites segment. For more information on other CVI Heartbites segments, as well as other CVI educational procedures and programs, please visit us at cviphiladelphia.org. Also, follow us on Twitter at CVI, also at the hashtag CVI Heartbites. Thank you for your time.